It's a privilege and an honor to be with you guys. I'm currently teaching at the University of Michigan and am in my office here, and I'm looking at you guys thinking you look warmer than I am. It's pretty cold here. So Miri Kim is the reason I'm here, and she and I have worked together, as I'll talk about in a little bit, and I'm thrilled to be with you. So I trained at the University of Michigan, where I returned as a member of the faculty. I was in practice in neurosurgery for about 30 years in Greensboro, North Carolina, with the largest private practice neurosurgical group in the country, Carolina Neurosurgery and Spine. And as we just heard, I kind of went through a very personally disruptive experience that led me to become a writer and to write about what I have gone through. I've become a teacher now. I joined the UNC faculty teaching medical students and residents, and now I've joined the faculty at University of Michigan. So it is a personal story, so I'm going to take you through why I'm here and what I'm about, and also what we're trying to accomplish. So my younger sister, Victoria, developed leukemia, had an AML, a bad mutation, monosomy 7, and had a bone marrow transplant and died. And that was in 2014, 2015. This led me to write a book called Grief Connects Us, a neurosurgeon's lessons on love, loss, and compassion. For me, it was a very disruptive experience that really reoriented me in the practice of medicine and the way I think about patients, the way I think about compassion and the importance of compassion and the care we provide. My younger sister was always in my life. She was 18 months younger than me. Here you can see, we grew up in DC. She was sitting on our mom's lap, we both were. We spent 4 years living in England in high school or junior high. After we grew up and graduated from high school, we went our separate ways. She went to college, later moved to Los Angeles and became an actress. And I went to North Carolina after training in neurosurgery at the University of Michigan. So in the fall of 2014, she developed leukemia. It started as what was a flu-like illness, and here she wrote a journal about her illness, and her goal was to share this as a one-woman play about surviving leukemia, and unfortunately became a testimony to her illness and later her death. And I didn't really imagine myself as a writer, but I wanted her words to continue on past her, and so I incorporated her journal into my book. But here she talked about the isolation that she felt, being yanked out of her life, being yanked away from her family, spending almost 4.5 months in the hospital. Here she had put pictures of her children and her family up around her, and here she was getting her head shaved. I was there visiting with her at the time. She was continually hooked up to IV poles. She used to call it her stalker. She had 12 pumps running all the time, and she was very frustrated because she never lost any weight despite not eating much. So most people in the hospital saw my sister as a patient in a gown, bald, head shaved, and very few people knew the person who just a month or two earlier was a vital mother of 2 sons, wife, and an actress, and producing her own films. And almost no one knew her as the young girl that I had grown up with and loving. And I realized this sort of led to a personal transformation. It was as if I suddenly went from seeing in black and white to seeing in color. Because this is the story of each and every patient that we take care of. And oftentimes we don't really recognize who they are, their stories, that we don't take interest in them, we don't see what's unique about them, and we kind of keep a defensive wall of emotional armor to protect ourselves. But I realized as I went through this experience, I wanted to get rid of that armor. A year and a half later, her husband, Pat, a year and a half after my sister died, her husband, Pat, ruptured an anterior communicating artery aneurysm in his brain. And he went into a coma and then was taken to UCLA Medical Center, where he was in the hospital for a couple weeks. I was his healthcare power of attorney, and I had to ultimately decide with his family to withdraw treatment. This is a picture of their family. This is Pat, Victoria, Nick, who's the taller child, and Will. And this was in happier times. Nick was the bone marrow donor for his mother, and he did CPR on his father, and really had a devastating change in their childhood. They're both now orphaned and are struggling to kind of become adults in a tough world. So in my book, I advocated for palliative care, for education and training in palliative care, and I realized that if I was going to become an advocate for palliative care, I needed to learn more about it. So I decided I needed to do this to grow as a person, to develop new skills as an advocate for palliative care, and to improve my ability to communicate and care for patients. So I went to Palliative Care Education and Practice, which is a program through Harvard Medical School, which was remote due to COVID. And it was a 2-week, sessions with a project with lectures and small group play acting and working with others. And in this, I studied and learned to develop communication and listening skills and skills maps, explored teamwork, role-played with professional actors, and had a safe space to learn and to grow. So we did new projects. One of the projects I did was with the CEO of our health system, which is Cone Health in Greensboro, North Carolina. And I'll show you a clip of a video of the CEO, Mary Jo Cagle, talking about her own experience. So I attempted to integrate palliative care into the clinical services in the neuro ICU. Here's Mary Jo. She's formerly an OBGYN, now full-time CEO of a health system, talking about her own experience with her mother, who had a subdural hematoma, went into status epilepticus, and later died in Alabama.
That the neurosurgeons, the critical care docs, they were incapable of dealing with this end-of-life issue and allowing us to meet my mom's wishes. And I very much felt like that to meet that, it was in my hands to do it. And it was one of the most frustrating moments that I've ever experienced as a patient family member, as a physician. I was so frustrated and could not believe this is the institution where I trained. And I felt that I was dismissed, and I couldn't even get people to look me in the eye and have a conversation with me over something that was not unreasonable. You know, we talk a lot about making sure patients have advanced directives and living wills. My mother had all of that. It was brought to them early. They said, make certain palliative cares involved. We had palliative care involved prior to her surgery. We had a plan, and yet none of that could be executed. So it's more than that. It is that all of our physicians have to have some training and some sensitivity to what it looks like to be involved with end-of-life care and understanding what patients and family members need.
I wrote an article about why a neurosurgeon should attend palliative care training, and that appeared in the Journal of Palliative Medicine. And since then, I've been working on integrating palliative care into neurosurgical practice. I think this is less a conversation about what advances in palliative care and more that we need to bring the principles and practice of palliative care into our field of neurosurgery. I think that care is often bifurcated. It's technical versus emotional and often split. And yet the emotional support piece is oftentimes what patients and families remember most and is the most important. And sometimes we leave that behind. In an acute care setting, the palliative care integration has unique requirements. I think one of the key parts of this is working as a team. We need earlier involvement, frequent touches, consistent messaging, and training. In brain tumors, I think this is a well-suited paradigm, and it's no accident that a lot of brain tumor programs have palliative care integrated into them. They're chronic conditions with longer-term relationships. At Cone Health, we started our own brain tumor program, which I was one of the co-directors of, and we had a multidisciplinary clinic with an embedded palliative care nurse practitioner, which we were able to address patient needs and quality of life, essential to the treatments we were providing. As I tried to develop palliative care integration in neurosurgery. I discovered it really wasn't something that was widely accepted, and we started a collaboration with residents, Miri being one of them, and Adela Wu at Stanford, Stephen Miranda at Penn, and we came up with a game plan of how we would implement palliative care in neurosurgery. I also got involved in Vital Talk, and I've become a trainer in Vital Talk. And I think this is crucial because it improves communications and increases resilience with decreasing ethical distress. And as I'm sure most of you know, it grew out of palliative care and oncology, and is a really good opportunity for us to develop training in serious illness conversations. At Michigan, we call it M-Talk because everything at Michigan gets branded with a block M. There's been over 1,000 people trained at Michigan, but until I started, nobody in neurosurgery and very few people at all in surgical disciplines. So we're talking about goals of care, delivering serious news, shared decision-making, and how to communicate about adverse operative events such as complications. The beauty of this is not only do you improve communication and care with patients and their families, but you decrease the ethical distress and burnout in the practitioners because you give them a path to be able to share what are often wrenching and guilt-ridden and difficult topics that they're not comfortable expressing. This is a paper about doing so in implementing communication didactics in OBGYN to talk about complications. And we have had an effort in neurosurgery to train residents in difficult conversations, but it really hasn't been implemented widely or as thoroughly as it should. And this responds to a call from ACGME to have better communication training for patients and providers. We went to the AANS, which is the American Association of Neurological Surgeons in Chicago in May, and we gave the first presentation ever in neurosurgery on the evolution of palliative care and its relevance to neurosurgical practice. And you can see Miri on the far right, but these are all the residents and also neurosurgeons and palliative care specialists. We all came together to put on this training. We talked about why we need palliative care in neurosurgery, the importance of teamwork, and how this is done outside of the US, including in Australia and other places where they have a greater integration of palliative care than we do in the US. We also provided a model for communication training for neurosurgeons. Palliative care needs to be integrated into surgery. It's part of the continuum of care for patients. And these are some of the slides that we showed at that presentation. And we have to bridge the gap between neurosurgeons and palliative care providers to provide a more seamless scope of care for patients. Teamwork and multidisciplinary collaboration are key for effective communication and compassionate, culturally sensitive, and quality care for neurosurgical patients. I want to share a little bit from Adela, who is one of the co-presenters, and here she is with the young girl on the right with her family, and she had her own personal story with her father who developed a brain tumor, a atypical meningioma, ended up having 18 surgeries and later died. And what was interesting when I talked to Adela is it's not one size fits all. She wanted to bring palliative care to her family, and she's at Stanford. They're very interested in doing so. But the parents didn't want it. They said that culturally they weren't interested in receiving any palliative care. So it makes a big difference where you meet people and where they're coming from. I think that one of the beautiful things about this of personal loss and grief and going through these experiences is it integrates your artistic side. And here is a beautiful article that she wrote about food and the importance it had in her father's care. Also, she's an artist. And she's worked on integrating, as I have at Michigan, integrating palliative care into the neurosurgical practice. And she's talking a lot in her work about cultural sensitivity across different ethnic groups. So what are some of the challenges of integrating palliative care into neurosurgery? You know, I was amazed. So at the time that we gave this presentation in the plenary session, one of the brain trauma researchers stood up and said that the number one cause of death in patients was the early implementation of palliative care. So nihilistic, therapeutic nihilism and withdrawal of life-sustaining therapies was the number one cause of death in traumatic brain injury. And I think one of the fundamental problems in the ICU is the difficulty we have with neuroprognostication and how we manage uncertainty. But I think we make a mistake. If you look at, and Claire Kreutzfeld is in Seattle, talks about the fourth trajectory. There are a lot of complicating factors, the disability paradox. If you ask someone when they're initially injured, do they want to live with that disability? They would say no, but later on, family and patient adapt and adjust. But we need to decrease suffering. We need to get rid of what is, I think, a very paternalistic attitude. And oftentimes when we say, well, we can't make decisions on whether to withdraw treatment, what effectively we're doing is abandoning patients in one of their greatest moments of need. And if there's such a focus in the ICU on throughput and getting patients out of the ICU or length of stay, that we end up doing a pretty poor job in terms of giving follow-up to patients or keeping with families. We also provide, I think, an inadequate amount of caregiver support. So is there a middle ground? Do we need to say and come up with standards to say we're going to refrain from withdrawing life-sustaining therapy for 5 to 21 days to set some standards that we can, guidelines that we can both use from both neurosurgery and palliative care, and look at how, so that we can provide that supportive care at the same time that we're not withdrawing care too early and letting people die when they may improve. The problem is if we don't look at patients in terms of what they're experiencing in their families rather than, so we don't look at them as people rather than diseases, I think we miss opportunities to connect with people. And some people really have poor quality of life, and continuing just to get to survival with the possibility of ending in a vegetative state doesn't seem that we're doing them any favors at all. So what are the next steps? So I've launched a neurosurgery communication training program. We've written individual cases in neurosurgery and are presenting that at various institutions. We're doing this in Australia. I did this at Duke. We're starting this in Michigan, also at Stanford and Rochester, University of Rochester and UNC. And we're with Martina Stipler and Kate Drummond, who are two neurosurgeons. Martina is at Harvard and Kate is head of neurosurgery in Melbourne, Australia. We're producing the first ever book on palliative care in neurosurgery. So I spoke in Australia. We are working to integrate palliative care and neurosurgery. I was amazed when I came to Michigan. I thought, well, this will be a snap. They'll want this. And I discovered, no, actually, people are very resistant to the idea of bringing palliative care into the ICU. We are, at least locally, much more receptive to communication training for neurosurgeons. I spoke at the International Neuropalliative Care Society, and there are great groups within neurology that are working on palliative care integration into the chronic diseases, including neuro-oncology, and I think we need, as neurosurgeons, to integrate into those efforts rather than try to reproduce them on our own. And I think so we're working on coming up with specific neurosurgical cases and also looking at best case and worst case scenarios for patients, which I think are particularly germane in surgical treatments. And at the University of Michigan, I just want to share briefly how we've launched this at Michigan with 2 3-hour courses with original cases. One was an intraop aneurysm rupture, also a glioblastoma where the patient comes back for pathology review and discovers that the tumor is more malignant than first perceived or thought of. Goals of care about a recurrent subdural hematoma where we say, well, should we go back to surgery or should we stop? So we're doing 2 courses. One is delivering serious news and the other is goals of care. I've launched the delivering serious news course with 8 neurosurgical APPs in person, and then we did 9 more remotely. And we're launching at the end of this month with 32 residents and faculty. The goal is to train 100 people in our department. And here's a shot of this in person. I'm working with the palliative care people. They run MTalk, and these are the APPs in that conversation. And here we are with an actor talking about her what was felt to be a low-grade glioma that turns out to be a GBM, and some of the decision-making that we need to make. So the results so far with surveys are 100% endorsement for self and for others, and 100% advocating for additional training. So I think there's a real important need for this in our field. One of the big issues is that when someone comes up with a question to you and it's a cognitive question, we tend to give a cognitive answer rather than recognizing the emotion behind the question. So starting to get smarter about how we address questions, I think, is a part of it, to respond empathetically to a patient or a family. So my goals are that we need to deliver compassionate care and chart our futures. We so often in neurosurgery, we tend to offload things. We become technicians. We're going to do the surgery, someone else takes care of the patient. And I think we lose our opportunity to have a meaningful relationship with patients. So we need to improve our communication skills, our collaboration and teamwork. And through research, we can come up with best practices where we can direct this care and provide the best care we can possibly for patients and their families. And this came out of personal loss and grief, but I feel, and I'm very grateful to my sister, I am grateful to you for listening, and I thank you for your attention.
Thank you, Dr. Stern. I'm curious, there's sort of two groups of patients for whom surgeons would be in a position to have these types of conversations. One is a group of patients where something happens to the patient, a stroke, a traumatic brain injury, some externality. The other is when we're caring for the patient and there's a complication in the course of their treatment, in the course of their surgery. How do we get the surgeons themselves to a point where they are cared for and they are in a mental place where they can be compassionate as opposed to suffering themselves, dealing with the negative emotions associated with hurting somebody unintentionally?
I think I'm really glad you asked that, because I think that's one of the goals of this training is that I think we tend to be avoidant, and I think it's certainly not from a lack of self-criticism. I think actually we beat ourselves up and we don't admit the basic fact, which we all know, and we can see the gray hair. We're not infallible. We are going to make mistakes, and mistakes and failure are an inevitable part of our field. I think that patients, we have this sort of perfectionism that we think we need to do things perfectly, and we berate ourselves when we aren't perfect. And families and patients, they want to know that you care, that you're doing your best. They're actually far more forgiving than we are. So I think you have to become comfortable being in that space. And I think a lot of times when we talk to a patient or a family about a complication, it's all from the standpoint of ourselves. Like, I failed, I made a mistake, or our guilt, or how we react to it, rather than taking a bigger stance and saying, complications can happen, and I feel badly about this, but I need to talk to this person and family about what's going on, where they are, what to expect, and really to be far more compassionate toward that person. So I think one of the problems is that we lack self-compassion, and we're also perfectionists, but we need training. This is a crucial part of our job. We're not all perfect. We're going to make mistakes. How do we communicate those effectively? And that's one of my hopes of the training, is that through training you will become more comfortable recognizing, admitting to complications, having the skills to deliver that message and the impact of that, rather than avoiding it or keeping armor up or keeping your distance. But we need training in this because complications are inevitable, and these conversations have to happen, and they have to happen with skill.
Thank you. One question from our online viewers. Dr. Sharma, who's a neuro-oncologist, states that she finds a lot of extremism on the part of neurosurgeons when it comes to brain tumors in terms of optimism or pessimism with regards to the outcome, and that sometimes that pessimism will cause a break or a rift at the beginning of a patient's journey. What would you propose for education around that, especially breaking news at the beginning of a highly malignant tumor?
I think that one of the big problems is mixed messaging or inconsistent messaging. So I think that, and one of the other problems that happens is that people pass the buck, right? I'm just going to avoid talking about it altogether. Someone else, the neuro-oncologist, will get to it. So I think that I do think that one of the ways that we can support each other and support patients is by having a unified message. I found the multidisciplinary brain tumor program that we set up to be very powerful, very supportive of the patient, their interests, and also bringing all of the clinicians together so that they speak with a common voice. So I think that very individualized presentations of information or extremes really have no place in this care, and you have to recognize I'm not just doing a technical surgery. I'm not going to say either something horrible like the GBM is incurable or untreatable, and that's that, and sort of wash your hands of it, or make the alternative case and say this is a super easy surgery, we can take this out, and then minimize the downside. I think that's irresponsible of us, and I think ultimately we need to do better, and we need to integrate our voices, hopefully at the outset of care.
Well, thank you again, Dr. Stern. Thanks for making all of us better doctors and capping off quite a morning. We're going to take a brief break, and we'll be back online on stream in about 10 minutes. Thank you.